Right. Okay. Let's move on to stress dosing of steroids, which actually is a very important topic, and I think it's much more pertinent given that there might be some steroid-sparing agents that may make the clinic in the near future, and more boys with DMD might stop steroids. And I think it's important that collectively, as a community, we understand this. It's going to be a few slides of biology lessons, and I hope you bear with me because this helps understand this topic a little bit more, because I think there still is a lot of confusion. So in this cartoon, you can see that there are the two adrenal glands which sit on top of the kidneys, but the adrenal glands, which make natural steroid hormones or cortisol, is regulated by a little pea-sized gland that sits in the middle of the brain called the pituitary gland. And the pituitary gland is the master regulator, or almost like the conductor of all hormones control in the body. It makes an important signal which specifically stimulates the adrenal glands to make this steroid hormones called ACTH. And it is an elegant feedback loop which keeps things going naturally. Steroid medicines, which boys with DMD take, like prednisolone or deflazacort, are artificial forms of steroids. But the dose that of prednisolone and deflazacort, even what seems to be a low dose for DMD, is actually a very high dose and much more than what the body will produce. And when anyone takes prednisolone or deflazacort, these tablet steroids, for more than a month, this really switches off the master regulator signal. So it dampens the pituitary gland from making the master regulator, i.e. ACTH. And as a result, the adrenal gland will stop making natural steroid hormones or cortisol and lead to a state of adrenal insufficiency. Some people say adrenal suppression from the use of hydrosteroid. I sometimes have used the word sleepy adrenal glands when I'm explaining to family, or indeed a younger boy with DMD, so they understand that. So to be clear, there's nothing wrong with the adrenal glands of a boy or man with DMD, but it's really the taking of these high dose steroid medicines, which leads the body to shut down its axis because it senses there is so much steroids floating around in the system. Okay, and hopefully we're clear on this. Without taking high dose steroid, in the normal situation, the body makes a certain amount of steroid hormone to keep us going, to keep us active, to give us energy. But with just like how we blink naturally or in response to dust in our eyes, with a minor stress, for instance, a viral illness with a fever, a healthy adrenal gland will mount a steroid response to make 2 or 3 times more of the natural steroid hormone or cortisol. And with a much more major stress, like, a severe illness, like severe meningitis or maybe severe COVID, the adrenal glands will make at least 5 times more, sometimes even 10 times more of the natural steroid hormone or cortisol. Another situation where this happens is that if any one of us who do not take steroids or healthy, we have an operation, for instance, and if we do measure the cortisol hormone over time, we can see that the cortisol level rises to many, many times. The prescribed prednisolone or deflazacort of ambulatory boys with DMD is usually approximately 5 to 7 times more of the natural production of steroid hormones or cortisol. So whilst the high dose steroids has led the adrenal glands to be shut down, the prescribed prednisolone and deflazacort is keeping that young person going normally. So that's okay. Okay. But the situation when steroids may need to be given in a different way are as listed as below. These are what I call major stressors. So in a severe illness, for instance, sepsis or meningitis, or a young person has some kind of an illness, we don't kind of know why yet, because most of the time prior to presentation to the hospital, you don't know what the diagnosis is, but it's very floppy and very lethargic, especially with a vomiting and diarrheal illness. And this, obviously, going back to the past talk, nausea, sometimes vomiting can occur with first bisphosphonate infusion. or also where there's a clear injury where there's significant deformity or the bone, the limbs look like they're broken. There's a clear cut fracture of the long bone and the boy is in significant pain and you need to call an ambulance. Or if the boy is going for scoliosis surgery or correction of contracture, so having an operation, or indeed even something simple like having an appendicectomy, because boys with DMD develop normal health issues as well. In this situation, obviously, steroids need to be given in a different way. And those in red are in situations where the parent or the caregiver may have to initiate or tell the first line health people, i.e. the paramedics, that steroids needs to be given swiftly and in a different way, i.e. with an injection. With an operation, obviously, the steroids need to be given via drip in the hospital. So in those situations, just going back to those situations as well at home, if you've got a boy with DMD, because they cannot take steroids because it's a severe illness, they're vomiting and they're in a lot of pain, and injection of hydrocortisone into the muscles is recommended as standards of care. Or if you're not trained to do that, you need to inform paramedic or medical staff of the need for extra steroids when unwell. And I think documentation, bracelets, for instance, this is something we've developed in the UK with Duchenne UK, and I'm aware of different patient organizations developing different bracelets and apps. I think that's very important to be able to inform paramedic staff of the need for extra steroid when unwell, telling them that they're steroid dependent or they have adrenal insufficiency. A mnemonic that I actually developed that a little while ago, I can't remember when, is last, and I think it's useful to tell doctors who often may not be familiar with Duchenne or familiar with this issue, is that during an emergency, giving extra steroids should not be the last thing on their minds. And you can tell them that your boy with DMD has been treated with long-term steroid, leading to adrenal insufficiency. He is steroid dependent and needs to be treated with extra steroids when unwell. And maybe this is something that you can remember, clearly works for English, but perhaps not for some of the other languages which, who are here tonight, I'm sorry. Okay, so steroid dependent, treat with extra steroids when unwell. So the standards of care clearly talks about the need for access to extra hydrocortisone. In the UK, based on some experiences, and I'm aware that in some countries this has also been developed, that there are concerns that even though the dose of prescribed steroids in ambulance boys with DMD is, like I say, at least about that 4 or 5 times, is usually sufficient to cope with the minor stress of a what I call mild illness. But in some places, on some sites, the dose of prescribed steroids in non-ambulant boys or in adult is reduced or halved, for instance, and it might just not be sufficient to cope with minor stress. There are also some concerns, and there's not very much research data, but there are a couple of cases which have, with colleagues in London in Great Ormond Street have described. There are some concerns, and certainly data shows that the Flazicort, the half-life of the Flazicort is actually very short, probably only about 90 minutes. So even though the dose of steroids, particularly the Flazicort, is high, it may not last over the 24 hours, especially during times of stress, like a mild illness. And therefore, not explicitly addressed in the 2018 standards of care, although it talks in a very vague fashion about stress dosing. In the UK, via work we've done with Duchenne UK, via DMD Care UK, with lots of consultation, we are recommending that boys in DMD, when they're mildly unwell, should also look into taking extra steroids and the various different recipes. So I just want to highlight this, and it's something that can be discussed with your clinician. So are the recommended standards of care in the 2018 standards of care that access to hydrocortisone at home to be injected in severe illness, particularly with severe illness, especially with diarrhea and vomiting. Some sort of a stress dose plan is needed. I think it's useful to look into documentation, bracelet, emergency cards, letters from doctors, apps. I really like these big cards that PPMD have developed that can actually be tagged onto a wheelchair, for instance. And clearly, adrenal insufficiency in the hospital setting is something that we see. So as an endocrinologist, I see many other patients with adrenal insufficiency, and there are local protocols already. But if you do end up in a hospital who do not have any experience with adrenal insufficiency, then the PJ Nikolov steroid protocol is useful for the doctors to actually use those treatment algorithms. So I'm just going to give you a couple of examples of clinical cases, and rather than actually testing you, which I did in a previous webinar, I'm just going to give you an answer. So hopefully with time, you will feel what needs to be done. So this is poor John, looks really green. He's a 10-year-old boy with DMD and is on daily prednisolone. The night before, he developed loose stools, and when he woke up in the morning, he vomited about 3 times within an hour after he took his prednisolone. He looks very, very unwell, very pale, really green here. And so the question is, what should you do? Give him another dose of prednisolone, give him some fluids and just ask him to sleep it, give him an injection of hydrocortisone and ring an ambulance, and I'm not sure what to do. Well, in this instance, I think the setting is that he looks very unwell. And in that instance, I think, an injection of hydrocortisone should be given at home if you've been trained, or you need to contact an ambulance and take him to the hospital and tell the paramedic staff that he needs an injection of a steroid because he has Duchenne and has adrenal insufficiency. Peter is 6 and is on daily deflazacort. He was walking his dog, he's tripped and fell on concrete, absolutely agony, large swelling on his left leg, and there seems to be some deformity. So what would you do? Just give him some painkillers and see how he goes in the next few hours? Do you ring an ambulance and give an injection of hydrocortisone? Do you ring the neuromuscular team, or do you give another dose of deflazacort? So I would say ring an ambulance and somehow give him an injection of hydrocortisone, either yourself or with an ambulance, but it's also useful just to tell the neuromuscular team that he's coming to the hospital, I guess, so that they're aware that he's presenting to the hospital. So again, this is a boy who's had a significant injury. It looks very much like a fracture, so not just like a small fall, basically. So Daniel is 11. He's taking daily deflazacort. He has vertebral fractures and he has fracture of the leg as well. And the endocrinologist started him on bisphosphonate infusions the day before. The next morning, he woke up with some of the typical side effects. He was feverish, he was very drowsy, and I think he vomited as well. So what should you do? Do you give him some paracetamol, ask him to just get on with it, have your breakfast, and give his usual deflazacort, or give an injection of hydrocortisone and ring an ambulance? And really an injection because he's very drowsy and unwell, okay? So not just that he's a bit feverish. So I think the key is that he's very unwell with that. This is one I actually developed a couple of months ago, and I suppose I could talk about COVID vaccination as well, just to make it topical. And I don't know that that's actually a right answer. Ewan is 13, he's on daily prednisolone. He tested positive for COVID-19. He is very, very well, but does have a slightly irritating cough and has no fever. And what should you do? I'm not sure. I could take that too. Take him to A&E, give him an injection of hydrocortisone, give him his usual steroids, give him his stress dose steroid by mouth, whatever your plan is. And I think this is a situation where I think because the young person is very well, and we do know that boys with DMD, even if they're tested positive for COVID, are actually surprisingly well, really. So I'm not sure that you're wrong to just give him his usual steroids and see how he goes with that, basically. So this is, I suppose, a little bit topical just with the current situation. So this talk is a little bit shorter, but I suppose I kind of want to end with about implementing care in the UK and how we're doing it in the UK. Via DMDK UK, we developed working group in each area, and I led on the endocrine and bone working group. And based on the 2018 standards of care, a group of about 5-6 of us endocrinologists looked at the areas which we thought should be implemented as a priority from the international recommended standards of care. We sought wide consultation, sending out to the clinicians in the 29 North Star centers, the neuromuscular and endocrinologists, asking for their comment if they thought what we said was feasible to be implemented. We developed some patient information leaflets on adrenal insufficiency and delayed puberty. And there was also consultation with patients within the working group. Within the bone and endocrine working group, our recommendations and the patient leaflets were also endorsed by the British Society of Pediatric Endocrinology and Diabetes. We held several webinars. We developed a DMD-specific emergency steroid card. We also recently performed a UK-wide stress dose survey in boys with DMD in the UK, and we are hoping to present it in due time. And once we're able to present that, we will tell you the results. But we also ask patients what they want, and the patients quite consistently want much more information and education in the area of steroids and also in the area of adrenal insufficiency and the need for refresher as well. So just to summarize, steroid treatment use in DMD as short as 4 weeks can lead to adrenal insufficiency, and extra steroids is needed during emergencies, particularly severe emergency. Education of the patient community is important because I think there's a lot of confusion out there. One thought is that perhaps some kind of structured online education can be developed, because sites might also have difficulty in doing the refresher courses or even training in the first time. But the main thing is to remember that steroids should not be stopped suddenly after using for a long time. Even when steroids are weaned to discontinue in some of the patients that I've seen, not just in DMD, but other chronic diseases, the adrenal insufficiency may persist sometimes months to years, especially in younger children. And therefore, an emergency plan needs to be in place after discontinuation of steroids. And I think it is high time that the community addresses this issue properly, because it may be soon that a larger group of boys with DMD may wish to stop steroids with the approval of new steroid-sparing therapies. So I think it's time that we collectively work together to spread the right information on this topic, but also assist our clinicians in addressing this issue. So thank you very much for your time again.